And I'm just going to go ahead and start, and I'm just going to, sorry guys, turn off my camera so that you can see more of the PowerPoint presentation. Okay, so most of you who received the calendar invitation saw information about CME credit. So we are providing CMEs for this training. This activity has been planned and implemented in accordance with the accreditation requirements and policies of the Accreditation Council for Continuing Medical Education, ACME, through the joint providership of Atrium Health, Charlotte AHEC. Atrium Health Charlotte AHEC is accredited by the ACME to provide continuing medical education for physicians. So for this particular training, it's 1.25 hours, and for other professionals, it would be 0.13 continuing education units. There is a registration link, so if you have not received it, please check in with one of us or Dr. Mehta. It is important that you register to receive the credit. This is our team. So currently it will be just me and Carissa. So I'll just introduce myself. My name is Marnell Gomez. I am the Training and Technical Assistance Manager for the NPPC, that stands for National Pediatric Practice Community at Center for Youth Wellness. And my director, Lena Singh, is actually on vacation, but she also would join the team when it comes to these presentations. And with me today is Carissa. Carissa, you want to introduce yourself?
Sure. Good morning, everyone. This is Carissa Luckett. I'm a nurse and a social worker, and I will be helping with the implementation training today, as well as providing coaching for your ongoing success as you implement ACEs screening. It's a pleasure to be with you.
Great. Thank you, Carissa. So just going over what the training will cover, we're going to review a little bit more about what NPPC is, some history around the organization, and what we've done with our pilot site, or in this case, with our partnership with all of you. We'll be reviewing the science of ACEs, or adverse childhood experiences, and toxic stress. We'll talk about orienting all of you to the ACEs screening, rationale, and protocol development, discussing specifically the Myers-Park screening protocol, and if we do have time, practice with some sample scripts, and reviewing education tools, documentation, and additional resources if applicable. So before I get into NPPC, I would like to talk a little bit about Center for Youth Wellness. We are a pediatric organization based in San Francisco. We're focused on early childhood adversity and addressing adverse childhood experiences, ACEs, in pediatrics. And we're excited really to work with all of you to improve care for patients and families affected by ACEs and toxic stress, and working to transform how the field of pediatrics addresses this issue. So we'll talk about how adversity plays a role in a child's life and how they can be resilient to it, and how being able to predictably and compassionately be available for children will help their resiliency, and using a formal screening tool will support and evaluate how best to do this process. So about NPPC, we're a learning community of pediatric medical providers who are leaders in advancing clinical practice around ACEs and toxic stress in primary care. Our goals are to engage providers as champions on this issue, provide tools, resources, training, coaching needed to make ACEs screening, and the integration of a toxic stress framework a reality into the practice. We really just want to become a hub for learning about ACEs and toxic stress as they relate to pediatric medicine. Our vision: all primary care pediatric medical providers implement universal screening for adverse childhood experiences and routinely use an understanding of ACEs and toxic stress to enhance the quality of patient care and health outcomes. So I talked a little bit about the sign-in sheet and how there's a section there about joining NPPC, and this is really what it's about. This project and what we're trying to do has a few different areas of work, and we've convened like a virtual community of medical providers interested in the topic. And we also provide direct technical assistance and training. directly to medical practices to implement ACEs screening. So working with all of you. So we're building a community. We online currently, if you sign up, there's about 1,000 providers that are already in this network. We launched it 2 years ago, and we're trying to get this many providers signed up, and we actually hit our goal, exceeded our goal since our launch. And so the website itself is the mppcaces.org. So when you say yes to enrolling, we'll go ahead and add your email address to that network. And here, it's a way for you to be able to commit to building a national community of medical providers using this online platform. We'll be able to promote shared learning, disseminate best practices, and really cultivate advocates in the medical community. All of our members will be able to access a comprehensive online resource center for tools and materials to support screening implementation. And then you'll also receive newsletters, announcements for any upcoming webinars or trainings, and up-to-date information from the field. So, long story short, please sign up or let us sign you up. We truly value our partnership. So here, this is just talking a little bit about how you will be able to share and coach and provide some information for you so that you can go ahead and start this at your practice, at your sites. We have yet to adopt an ACEs screening protocol. So we provide tailored support, training, technical assistance, and coaching around all the aspects of developing and implementing this protocol. We know that this is, implementing a screening can be complex and does take some time. So we have these tools and can share expertise to help you in your practice implement this actual screening in an effective and efficient way that would be less disruptive to what you're currently doing at your sites. So now that you got some context around what we're trying to accomplish with this project, let me go ahead and talk about the ACEs science. Okay. So ACEs, or adverse childhood experiences, are potentially traumatic events. These are experienced before the age of 18. The term ACEs comes from the Adverse Childhood Experiences Study, or ACE study, conducted in 1998 by doctors Vincent Felitti and Robert Anda. This was actually one of the largest investigations ever conducted to assess connections between experiencing adversities in early life and having health outcomes as an adult. The study is the basis for 10 core ACEs, as you see in front of you. They're categorized in 3 categories: abuse, neglect, and household instability. So these include physical, emotional, and sexual abuse, physical and emotional neglect, and living in a household where a member has a severe mental illness or substance dependence, where a child has witnessed violence against their mother, or where there has been separation, from a caregiver due to incarceration, shifting parental relationships, or divorce. Many ACEs screening tools screen for additional adversities in addition to the core ACEs I just mentioned. These include hardship or significant life events such as the death or illness or separation from a caregiver, forms of any violence and bullying and discrimination. These experiences impact a child's health in the same way as the 10 ACEs. So screening for both ACEs and additional adversities provide a more comprehensive assessment of risk factors for long-term health in a child by combining both individual and community environmental level health items. So I'm going to just briefly go over some of these statistics with these studies. What this slide shows is actually that it's pretty striking. ACEs are incredibly common among the population, with over 2/3 of the adults population having experienced one ACE. We have data that shows that nearly half of all children today have experienced at least one ACE, and that ACEs accumulates over childhood. So this is just some broad national and North Carolina specific data that we've been able to locate. So here you're going to see in the state level for North Carolina that nearly 24% of children in North Carolina have experienced 2 or more ACEs, and almost a quarter have experienced at least 1 ACE. So we have data that compares what a child in North Carolina who has 1 or more ACEs may experience, both good and negative compared to nationally. Of course, we know that while the prevalence of ACEs is common across race, gender, class, and other groups, certain groups are still disproportionately impacted. So those who might be most likely to experience ACEs may certainly find that adversity exacerbated by environmental and structural factors such as poverty, racism, and discrimination. As I'm going through these slides, like I said, if any questions come up, please either write them down or have them ready, because we definitely want to be able to address this, because there's a lot of content that I'm kind of overviewing pretty rapidly to stay on track. So this slide right here, this is the ACE study and subsequent research. It has pointed to a dose-response relationship, meaning that the more ACEs that someone has, the greater their likelihood of negative health outcomes in adulthood. This includes the leading causes of death in the US. Things like heart disease, cancer, chronic lung disease, addiction. So this slide shows with 4 or more ACEs, people are twice as likely to develop these diseases or cancer, and 3 times as likely to have chronic lung disease, and 11 times as likely to develop Alzheimer's. So we're talking about ACEs as a potential root cause of some of our most costly diseases. So here, this is showing that ACEs doesn't just impact health in adulthood. Many of the health and developmental concerns associated with ACEs also appear during childhood. Among infants, studies have found associations between ACEs and growth delay, cognitive delay, and sleep disruption. In middle childhood, we find associations between ACEs and asthma, learning difficulties, and behavioral problems. And in adolescence, we find associations between ACEs and violence, bullying, smoking, teen pregnancy and teen paternity, and weight management. So the question is, how do these early social experiences turn into health damaging ones? So what we now understand is that these early experiences act as a stressor on the body, and in doing so, activate our stress response. With the stress response, it's highly adaptive and generally functions, while the stress response is highly adaptive and generally functions well, when it is overly activated over and over again, it really becomes health damaging. So this is actually a spectrum of the stress response, including positive, tolerable, and toxic stress. The physiological response to stress depends on the nature of the stressor and the ability and availability of buffering and coping strategies. So a positive or tolerable response is characterized by the return of homeostasis, whereas a toxic stress response may induce lasting changes. So when I've talked about this with children, we actually did an event on this past Saturday where I was talking with the community that our agency is located at. We were telling them about what's the difference between being stressed regularly and then having this kind of overwhelming stress. And so we compare it a lot to taking a test, something that they can relate to. And what I found out with kids is that they always say, oh yeah, when I'm about to take a test and I'm not prepared for it, I get really nervous because I don't want to mess up. I want to do really well. And then I'm like, okay, so after the test and after you take it, how do you feel after that? And they said, well, if I studied, I feel great because I feel like I answered a lot of the questions right. But if I don't study and I didn't prepare, I still feel kind of nervous. And I'm like, how long does that feeling last? And they're like, oh, it goes away after a while. I get distracted, I play. And these are kids probably like early junior high, and they're old enough to have conversation with me. And then I said, but what happens if like that stress doesn't go away? Like you're always nervous, you're always thinking that you might mess up. And they said, well, it actually makes me feel sad and makes me feel like I can't really, and it's hard for me to get over. So we're just trying to identify the difference in feelings, right? Because a lot of the kids associate feelings around stress. And so that was just a way of me being able to engage with the community, talk to them about what we're trying to do. And it was interesting to hear that the kids wanted to ask these questions and talk to us on a more regular basis. And I was surprised myself because I was thinking, oh, you still want to keep going with this? I thought you were going to be like running away from me at this point. So it was nice to have those conversations with just to find out what their understanding of stress is. All right. So toxic stress is characterized by prolonged or frequent activation on the stress response caused by factors such as ACEs that leads to the disruption in the way our neuroendocrine and immune systems work. So leading to more negative health impacts. Some of the impacts for the neurologic effects can include overactivity and difficulty turning off the stress response. This increased fear response or increased risky behaviors. The immunologic effects can include increases in infections and chronic inflammation. The endocrine effects can lead to changes in hormones related to growth, puberty, and metabolism. And research has also found epigenetic effects, which includes changes in the way DNA is read and expressed, increased risk for diseases such as diabetes and cancer. There also can be substantial individual variability in how early adversity and toxic stress shows up over the life course. So this image, we see a few different possible trajectories as examples. First, starting at the top, it is possible that an individual who experiences ACEs doesn't present any symptoms and ends up having a pretty healthy life. Moving to the very bottom, we see an individual who experiences toxic stress. We see that disruption which manifests as social or cognitive impairment, leading to the adoption of health risk behaviors and leads to disease or disability. These are likely individuals that some of you who are providers already identified through your practice as needing extra support or intervention. Those who have behavioral symptoms are in many ways the lucky ones because they usually receive some sort of intervention. Because in the middle, we see a child who has experienced toxic stress, but perhaps doesn't present the most obvious behavioral symptoms. Perhaps their symptoms are kind of, it comes in the form of uncontrolled asthma or ADHD. So perhaps this child has no recognizable symptoms, but as an adult, still experiences premature disability or disease. This shows the importance of screenings as not one person will experience things in the same way. But we also know that some individuals do and some individuals don't experience toxic stress as a result of negative experiences. So there's a lot of individual variability, right? So think of this as like a scale weighing the things, weighing both good and the not so good that may affect a person's health. The positive things are called protective factors, things that help create a safe and stable foundation for a child. But the other end holds the bad things, or what we call risk factors. ACEs are known as risk factors. So there's this fulcrum, this middle ground, which is an individual's biology, their genes. Our biological makeup may make us more or less susceptible to a stressful experience. So this fulcrum, where the fulcrum is positioned on the scale, which would be different for every person, affects how much leverage either protective or risk factors have in shaping our life outcomes. So for example, someone who has their scale weighed down by risk factors and is also more biologically susceptible will be at greater risk for stress-related diseases. Okay, so this is just some information around the ACEs science. Before I transition over to Carissa to take us over to the ACEs screening and more site-specific information, I wanted to pause here for questions. If any of you have any, please let us know. And Carissa, if you want to go on camera if in case there's some questions that come up.
And any questions? Okay, if you think of any, please feel free to type them in the chat box, or we'll have some additional time at the end for questions. Okay, I am going to talk to you today about the ACEs screening. Go ahead, Murnell. So we know a couple of things about screening that are critically important in the success of implementing in a pediatric practice. Adverse childhood experience screening is ideal in this particular healthcare setting because of all the work that you all do naturally every day, talking about health promotion, disease prevention, all of the other screenings you do like MCHAT and depression screening. So screening in a primary care pediatric setting is common, and it's a great place to integrate this discussion because of the closeness that most families feel with their pediatric team and their providers. We also show and know that early detection related to ACEs provides us an earlier opportunity for screening, and therefore families that are screened earlier can continue to have interventions and build those resilient or protective factors. Okay, next slide. So the way we approach this actual project is to look at it and frame it as a performance improvement activity. So I'm sure you are all familiar with the PDCA. So actually several months ago, we were on site in your lovely area, in your clinics, taking tours, doing a large part of the planning piece for this, understanding the patient population you'd like to have screened and talking about when to screen, coming up with a rationale for that. Today, we are actually completing our do part of this with training. We finalized your workflow and have definitions for the measures. And very soon, you all will start the check component. And we'll look and see how things are going with monthly calls with Dr. Mehta and the team. And we'll continue to learn what we can about ways to refine implementation and summarize that at the end of the 6 months with a written PDCA. Next slide. So here you can just see a summary of those phases as we go along. As we finish the first phase, we'll start a second 6-month cycle. Next slide. And so at the end, you'll have a year of data. Next slide, please. So let's talk in particular about your screening and get out of the theoretical and get down to how we're going to do it at your office. So we have determined the rationale for screening. We've gone through all of these key steps, and the critical thing that I would like for you all to know is this has been developed in close collaboration with the leadership in your clinic and has really been planned to be as least disruptive as possible to your current workflow. We'll have a scoring algorithm, and we have specific educational handouts and teaching tools for you to use so that implementation is as easy and as least complicated as possible. So as we talk to the leadership at your clinic, we have heard that early screening is important so that we can have the opportunity to better assist your children while they're there on site in clinic. That you would like to improve more internal systems and create a more thorough and intentional approach to trauma-informed care and connecting your patients better to services related to toxic stress. For your clinic, we'll be screening the 3 and 5-year-olds at their annual well child visits. Plus, at the 520 clinic, we'll be screening those children that are there for obesity. So I think it's important, and in your packet you should have a copy of the tool. I'd like you to flip over to that now and take a peek at the CYW ACE-Q. This is the child report. So the parents will be filling out this tool for their children 3 to 5 years old at their annual well child visit. A couple of things that I think are important to understand is that this tool is what we call a de-identified ACE-Q questionnaire. And so if you look to the right where there are those 2 big black boxes, we are actually asking parents to read the items in section 1 and put the number of experiences their child has had in that top box. These are the core 10 ACEs. Then at the bottom, you'll note there are additional questions. These are the other adversity and social adversity questions that we alluded to in the beginning that create a very thorough review of stress causing factors in childhood. And so we again ask the parents to read the items in the bottom section and put the total number that they have experienced or their child has experienced in the box to the right. So some of you may be asking, why aren't these questions all yes or no? And that's a great question. If you were using this tool to screen for abuse or other specific adversity items, you would want to ask yes or no questions. But the really important thing to keep in mind is that this questionnaire is a screening tool for toxic stress related to adverse childhood experiences. And we have found over and over, and in our own experiences and through the research and literature, that de-identified questionnaires such as this produce more accurate and honest results from parents. So this is just step 1 in the screening process. We would never ask you to change your current clinical judgment and the way you currently already screen for abuse, using your clinical judgment, looking at signs and symptoms for abuse. And if you have other concerns about abuse, we would certainly ask you to do a further assessment. Next slide. So as far as your specific workflow, administering the tool, handing out the tool, and giving a brief description of how to fill it out will be done with the nurse and the nurses once the patient is in the room or has already been roomed. So nurses, you're going to have a really important and critical role to describe the questionnaire to families about how to fill it out accurately. We find that this is one of the most important pieces in a successful screening is explaining how to fill out the questionnaire And so we'll be working directly with you today to provide some opportunity to practice that, and we also have some sample scripts for you to use. So the nurses will take the final document that the families filled out and score, just add up the top and the bottom sections and document these results in your EMR and transfer or transition any of that information over to your medical providers. The medical providers will then review the screener, assess the patient for symptoms, and document those presence of symptoms or lack thereof in the EMR, and then determine the next steps for follow-up. In certain cases that we'll go over in just a moment with your scoring algorithm, a referral will be made to social work or other appropriate supports and linkages. Next slide. So we are going to consider a score of 0 with no health symptoms or issues to be a low risk for toxic stress. That makes sense. The patient and family have a 0. Now, we're going to go ahead and provide or have the nurses provide patient handouts that you also have in your packet on what are ACEs and what is toxic stress. And the provider will follow up with some additional anticipatory guidance on those actual handouts. Now, patients with a score of 1 to 3 with no symptoms would be considered an intermediate risk, and they would be handed patient education related to ACEs and toxic stress and any of the additional handouts to build up protective factors or resilience. Additional referrals may be made, like to CC 4C or Triple P, or other in-house services like your social workers. And the doctor or the other clinical providers will schedule a follow-up as necessary. So they may ask for that patient to come back in 3 to 6 months to just see how things are going and follow up with them with regard to services. Now, the patients that are going to be considered high risk will have a score of 1 to 3 or any score of ACEs adding the top and bottom section together of 4 or greater. The patients with a score of 1 to 3 will also have symptoms. So they already have a physical manifestation of toxic stress, or again, any patients with a score of 4 or greater with or without symptoms. Again, we'll provide that education and anticipatory guidance on ACEs and toxic stress. There will be a referral to a trauma-informed therapeutic services, such as clinical social workers or other mental health services, and the provider will schedule a follow-up to monitor those physical symptoms. Okay, I want to stop right there and ask, are there any questions?
Are the forms in Spanish?
Yes.
They are? Yeah. Okay.
Script as well.
We will work on it. Carissa, do you guys already have scripts in Spanish?
Yes, we do. We sure do. And we'll send those along to you. That's a great question. So the scripts are available in Spanish, and we will forward those to you at the close today. Okay, next slide. So for the medical providers in the room, you may be wondering, so what are these symptoms that are related to toxic stress? The good news is we have the symptoms broken down by the neuroendocrine and immune response and cascade that we typically see and that are correlated with actual ACEs. and by age group. So this checklist has actually been built into your electronic health record to make it easier for you to document the presence of these symptoms. I would like to just point out, in the case, if you look under the immune inflammatory section where it says asthma and eczema, allergic rhinitis, we are not stating that ACEs have a direct correlation with the presence of asthma. What we're saying there is there a history of uncontrolled asthma attacks or a recent increase in asthma? But that was just really a long phrase to type out there. So bear with us, and please just keep in mind, this is like an increase in any of these symptoms or having difficulty getting them under control with your regular and normal clinical interventions. Next slide. So clearly, I just would like to add that when the team are implementing assessing here, you can really see that having a knowledge of your patients and having the wonderful clinical experience you have is critically important. And your clinical judgment certainly does not go out the window with this screening tool. It does require that you continue to use your judgment to assess the presence of those symptoms. Now, once you find symptoms or once you start screening, step one will be to access the clinical forms section and to go to the ad hoc icon. You'll then click on the child folder, and under that, the ambulatory child visit. And don't worry, there'll be screenshots of all of this and a handout for you. And this, as you know, pulls up the normal intake. Next slide. From there, you'll be able to click on the pediatric intake form and scroll down to the left and click the screening tab. Now, on the developmental screening tab, down at the very bottom, you'll see a place that says Chart Pearls or ACEs screening. So you'll say yes there. Next screen. And then this will help to pull up the pediatric flow, the view in the ambulatory workflow for the providers. Then you can go to scales and assessments. You type in the ACEs screen. Next slide. And this is what will come up. And so you can see here, we have gone ahead and built out the availability in case you, for the future, if you screen adolescents, we have an adolescent self-report form. So we went ahead and built that in where the child can score for themselves. So right now you'll be using the patient or parent caregiver score for the child for section 1 and section 2. Those scores will auto-populate the total. And we would ask here that you would document if the caregiver refused the screening. If they said they didn't want to fill it out, which is fine. If you have a parent that's resistant, that's okay. It's a work in progress, and we still have the opportunity to talk to them about ACEs, and as I like to say, plant the seed. Next slide. From there, you can see that when the provider comes in, they will assign a risk level, high, medium, or low, high, intermediate, or low. And then this is also where they can assign symptoms, just as the document that we looked at, or the slide we looked at before, with symptoms by ages and systems of the body. Next slide.
Carissa,
Yes.
can I intercede real quick? So the system is actually designed to calculate your total score and the presence of symptoms or not to determine your risk level. So it should automatically calculate if you click symptoms present or not.
Oh, that's right. That is right. The box up to the top left. So that should assign the score for you. Very nice. You guys have one of the most sophisticated IT builds we have ever seen. So I commend you and hug your IT person next time you see them. Be kind to your friendly IT people. Okay, next slide. All right. And then at the bottom of that screening, it just gives you an opportunity to document what actions have been taken. So you can check whether the patient got their handouts on anticipatory guidance and toxic stress. And then you can see a little summary underneath if they're intermediate, what types of referrals or care considerations need to be made, and then a way to document those specific referrals that may be outside of your clinic. I know it's cut off just a little bit, but in this particular screen, just to the on the bottom left, that total score of 4 is there, so you're able to see that, and that's one continuous screen, but there's a spot there for you to reference the score in the bottom. Again, an excellent build. Next slide. So I share these four performance measures with you simply because I want you to understand it's critically important to capture a couple of those elements that have specifically been built into your EHR. Of course, we want to know the number of patients that are screened every month that are eligible. We also want to know the percent of patients that have a positive score, and we have conferred with Dr. Mehta and the team, and we would like to know the patients that have an intermediate or high score designation, and we're considering those positive. We also want to know the percent of patients that have a positive score who already have either been linked to services or are being referred to new services. So Renelle, can you go back one slide? I just want to highlight this for everyone. So this referral piece right here is critically important because it's going to indicate, and filling this out accurately is going to be important. For those patients that are intermediate or high risk, we're really going to need to know whether you've made a referral, whether they declined a referral, or they're already in services. We can go back to the next slide. So that gives us our third measure. And it's really important to capture those patients that may already be in services, the ones you've already identified. These are likely going to be the high-risk patients, but we want you to get credit or not have an inaccurate percent of patients in services who have positive screens. So that's really important. And then capturing, again, where I alluded to early on, the patients that refuse the screening. It's okay if there are refusals. We typically see that pretty commonly in the beginning. And as we get better and better at describing the tool, we typically see those refusals go down dramatically and very quickly. Next slide. So we're going to have a little practice section right now. So I would like to give you all a couple of minutes, and so I want to hear lots of chatting in your room because you all are going to turn to your neighbor and practice explaining to them what ACEs are and what is toxic stress. So here's the question. A family member grabs you in the clinic and says, "Hey, I heard that you guys are screening for something called ACEs. What is that? And why are you asking these questions?" Okay, go. Be mean to each other. Somebody be the Henri family.
You gonna feel it out. Screenings tool, you're just going to answer these questions. You're just going to put that final number in that box. It just kind of deals with stressors, how your child grew up, how you feel your child is growing up, if you have any concerns. Well, how did you go for it? No, ma'am, you can fill it out right now. It is. It is, because if you feel like once when you start kind of adding them all up, you might realize, wow, maybe we actually do this. You do a midterm on Espanol interpreter and Catherine was like, what do you know about competition? And I was like, we're just going to have Uncle Team Pound. Oh, no. Yeah. Especially with these people coming that are like emigrating and, we're like 6 years, her dad's getting deported, and now mom's like, I don't know who to pay the bills. I was reading over this and I was like, I pretty much checked like almost every box. I was in foster care. Yeah. Before like my mom found out that I was in foster care, she's like, let me go get that girl. I don't remember. Yeah, I don't know. Yeah. That was out dark. How'd I do? He's a good kid.
All right, you guys sound like you're doing a great job.
I know. We got serious.
All right. Good job. Good job. Does anyone want to share a
We're shutting them down. We're going to refine our process.
Dr. Mehta?
We're going to stop by the anyway. Hey, Carissa.
Yes.
We're also going to try and take a break and have our registration staff head out as well. Once you're out.
Okay. All right. So how was it? Does anybody want to share their experience?
Don't be shy.
Yeah, don't be shy. It's kind of weird explaining it the first time, isn't it? I really have struggled in the past with getting a phrase down that feels really comfortable to me. And so once I did, I wrote it down, and that's kind of my go-to phrase. And so I typically say, we ask about ACEs, which are just really difficult experiences, because we care about you and we want to know the things your family's been through so we can provide you the best care possible. And I mean, that's just my go-to line. And I have memorized it, and if I spoke Spanish much better than I do, I would memorize it in Spanish too, because it's very difficult to think about translating that in your mind in real time. And so the more comfortable we seem talking about ACEs, the more comfortable families are in sharing their experiences with us. So let's go to the next slide. Let's go to the next one, tumor now.
Hang on one second.
It's not playing nice.
It's early. Oops, sorry.
No, go back one. There we go. So here it is. So if you are administering the questionnaire, if you nurses that are going to be giving it out, or should ever someone else get asked to fill out the questionnaire, here are some easy ways to actually hand the questionnaire to someone and explain it. So just to say, we have some forms that we'd like you to fill out so your doctor understands better how your child is doing. This one is called the ACEs screen. We screen all of our patients here ages 3 to 5 so that we can understand what they've experienced. And then this is critically important to say. So when you look at the form, write the number of events or experiences or items your child has been exposed to. You don't need to circle, just write the total number at the top and the bottom of this form. So again, that's critically important to have the questionnaire filled out correctly. Let's look at the next slide. So if you're a provider or you're the nurse who gets asked, why are you guys asking us these questions? Again, you can certainly say, we ask about ACEs because we care about you and want to understand what your child has experienced or what you all have gone through. And the more we understand about you, the better we can support you. If there's a score that is an intermediate or a high, this is a nice way for the provider to transition the discussion to say, I looked at this questionnaire that you filled out, and because of what your child has experienced, I'm concerned that this may be contributing to some of the problems that we've been discussing, like the uncontrolled asthma, or like all of the abdominal pain your child is experiencing, or the frequent headaches. And then to follow that up with, the earlier we can address the stressors, the faster the body can begin to work to adjust and heal, and we can work together on that. So let's look at the next slide. All right, well, this is a case study. So I'm actually gonna go back. Yes.
Sorry, I'm gonna actually let our registration staff head on out so they can start.
Perfect.
If that's okay, we can take just a quick 2-minute break and let the folks that are doing registration in to, if you want to stay, you're welcome to stay, but we're gonna just go through some cases from the clinical side. So. Thank you guys all for coming. Thank you.
Thank you guys.
Thank you, everyone.
Have a great day.
We appreciate your time.
Thanks, Krista.
All right, so I'm going to turn my camera on so you can see me a little bit. I want to talk through these case studies. So in this example, the patient has filled out a score of a 2 after the nurses explained it beautifully, and this has all been logged in the chart. The doctor has not come in yet to assess further, or the provider. So nurses, at the moment, what score would this child have with the information you have? As far as risk, I'm sorry. Low, intermediate, or high risk? Very good. Now, you all are going to have the experience at times where a patient family discloses to you symptoms that you may need to hand off to the provider. So that's why I like to point that out here. I have a really good example where a nurse told me that she handed out the screener, and while she did some other things in the room, she just said to mom, "How are you doing?" And the mom said, "Well, I'd be doing fine, except my 5-year-old has been biting kids at preschool, and if she bites anyone one more time, if we have one more incident, she's going to be expelled." So you already now have some symptomatology issues identified from the parent, and so that'll be critically important that you hand that off to the provider. Just make sure you know how it is. Moms disclose something to you, and you just want to make sure the whole team knows that. So in passing, say, "They're having some biting problems at school. Just wanted to let you know." So that would change their risk from an intermediate to a high. So that's important that we talk through that. Okay, let's look at the next slide. All right, so this one is a 4. So with or without symptoms, a 4, just in case you had a downtime and the computer wasn't being nice to you, what risk level would this child be? High, that's right, very good. So you would anticipate an additional referral and probably a follow-up visit with the provider as well. Okay, next slide. Now this one is really sneaky, okay? I don't want to scare you or make you feel concerned, but I want to address this because it'll be an important consideration. If your patient family writes that they have a 10 at the top, there are some special actions that you're going to have to take next. Does anyone know what those are? That's a good point. Make sure they understand the questions. If the mom says, "Nope, we've been through all 10 of those," then what are you going to have to do? What'd you say?
Call the social worker. Paging O'Grady.
Yeah, you absolutely will have to do that. In this instance, this is a clear indication that all 10 of the ACEs have been experienced, and we know that several of them include physical abuse and neglect, and so therefore this would be a mandated reportable case. Now I will tell you, we have gone live with 6 practices now, almost 8 actually. You guys are going to be number 8. We have never had a 10 in any of those clinical care settings. We have had 1 or 2 at Bayview, and this is the clinic that CYW is affiliated with, and this policy that out of 10 it is a mandated reportable is not only from our clinical judgment, but also from extensive communication with our legal team and outside legal representatives. So legally, when you have a 10, you have to make the mandated report. A lot of times we have heard in our clinic affiliated with CYW that either 1, the families are already known to the provider and this has already been reported in the past, but you do need to verify that. So I just throw that out to you so that you know if a patient scores a 10 in the top box only. This would not be if they scored a 5 in the top and a 5 in the bottom. That 10 would not require mandated reporting. Only if it's a 10 in the top box, because you know they've experienced all 10 of the core ACEs. Does that make sense?
Yes.
Thank you. I don't hear nodding very well anymore, you know, age and all that stuff. Okay, next slide.
Can you elaborate as to why it needs to be reported? I know you kind of mentioned it, but.
Sure. So the reason that we would need to report, this would be a mandated reportable, would be because if you read through each of those items, someone touched your child's private parts or asked your child to touch their private parts in a sexual way. That means they've experienced that. More than once you went without food, clothing, or a place to live, and no one to protect. So mandated reportable for neglect there. The question right above, someone touched me, has to do with physical abuse. So those items related to physical abuse, sexual abuse, and neglect are covered there in those 10 core ACEs. Now, we're not, I'm sorry?
Are there any exceptions to making the report?
No, you would, if there's a 10, you would need to at least make a report to CPS unless you, there is one exception. If you have already reported the physical neglect, sexual abuse to CPS in the last 2 or 3 years, then you do not need to report it again. If you're already aware of that, you have documentation of that case report, you're fine. So, are there any other questions about that? Are there concerns about this piece?
Clarissa, I have a question.
Yes,
In the
ma'am.
clinics of locations that have went live, have you seen the need for more social work help in those practices?
That's a great question. What we have typically seen is about 80% of the screening, the patients screened fall into that, let me back up. 80% of the patients that are positive typically fall into that intermediate risk level. And what we see there are more needs around social determinants than psychological or counseling needs. Their housing, their parenting, their, some coaching on sleep, nutrition, just better coping mechanism needs, more transient stressors or new stressors. And so that's great news because 80% of those patients that have a positive screening are kind of in that middle risk. They haven't gone so far that they need the mental health piece. So that's where your internal referrals, many of the classes you offer, some of your other community resources are very useful in addressing those needs. And if the need is there, and you would like the staff to be better prepared, or you have a social worker or case manager role that you'd like to expand, we have additional training on care navigation, helping connect families to those resources. That's a great question. I will also tell you in our previous pilot implementations of several thousands of children that were screened, it ranges from about 20 to 30% score either in the intermediate and high risk. So you're looking at a small population of all the patients that you screen that will be in either of those 2 risk categories, which corresponds to the national data as well. So we've seen that repeated over and over. All right. I'd like to take a moment and have you all practice. So go ahead and go to the next screen, Murnell. If you could practice looking to your neighbor and just hand them the questionnaire to fill out if you're a nurse. And if you are a provider, let's go ahead and have you pair off and talk about how you would address whether or not the screener was positive. And I'm going to give you just 5 minutes.
Oh, you can try it. I'm not.
Here, close up.
I don't know. I wasn't. Let's just pretend. This is hot. Yeah, so mom filled this out. She seemed to understand it. She has a 7 up here and a 2.
And so that was you and
Yeah. Yeah. There. That was easy.
why do you think I did social work?
See, I don't know. I wouldn't feel comfortable opening up that Pandora's box. Like if I see 7 and 2, I'll just say, okay, great. I'll get. Right. Like until I get more comfortable with it, I wouldn't feel comfortable. Right. I wouldn't feel right. Like if mom wants to vouch for information, like if she wants to talk about it, that's great. But if she just put 7 and 2, then I'll just say to the doctor, make them aware. Oh, I'm not going to open up that box. Be like, oh, I see a 7. Let me go call our social. Oh, right. No. Ain't nobody want that box open. So I guess up front, no longer going to hand them out. I guess.
Oh, that's generation. Yeah.
So does that mean like we have to like? No, they're going to say, oh, in the afternoon, Dr. Redmond about the that Brett Reed paper. So I guess now we're
Well, the thing is doing that green side. So you know what they're doing.
Right. Well, I guess right. My mom can be filling out while we're doing blood pressure and size or here. And then they start yelling, I'm stressed. And then the kid starts crying, and I'm like, oh. I like this. Part of my oh, those 2-year-olds. Yeah.
All right, I'm going to try to get everyone back to the slides. Dr. Mehta? Yes. All right, let's get everyone back. You guys were having way too much fun. So I just want to share with you, as we're running a little bit shorter in time, I want to share with you these 3 patient education handouts that we are providing along to you with about 7 others as well. So when we talk about giving the patient families handouts on what are ACEs and toxic stress, these 2 to the left and middle are the ones we're talking about. You'll also have at your avail this handout on how to reduce the effects of toxic stress. Next slide, Murnell. And in the packet that you should have what we call job aids. And there are little conversation starters for each of the handouts that we have provided for you. So in the full packet, and you guys just have a tiny piece of it today in front of you, you'll see a job aid. That's our weird name for it, for every single handout we have. So if you're the nurse or the provider handing out the what are ACEs handout that you see here, I often say things like this. When I first heard of ACEs, I didn't understand them. We always have to have a fancy name for something in the medical field, right? So ACEs are really just difficult or stressful times in our lives. And this sheet gives you some examples. Go to the next slide, please. This one on toxic stress, I think, is great. I think that our newly designed toxic stress handout looks a little bit different, but again, it does go over the fact that the variability in toxic stress can affect your body. So an easy thing to say with this, and again, we would encourage you to customize the job aids to whatever works best for you. But if you grab this handout, I would recommend that you have maybe some laminated copies of the job aids right there, so the provider or the nurse can just take a quick look. I'm giving the toxic stress handout. Here are a couple things I can say. So an easy thing to say with this handout is having a lot of stress over a long time can make you sick. Do you think this could be happening to your child? We want to know so that we can help. It's very straightforward. Next slide. So I just want to remind you of a couple of things. If the patient doesn't seem receptive to taking the questionnaire, just give them a handout on what are ACEs, and let them know that it's fine. If you don't want to answer these questions today, that's fine. We just want to make sure you know about it. These adverse experiences can lead to illness, and we want to make sure that we continue to talk to you about that because we care about you. Again, if the patient is willing to tell you about their problem, and so for the providers, as you are going in to kind of assess a little further about what's going on, don't forget to use open-ended questions. I think a great way to start that, because you don't have to unpack everything the first day. Helping families deal with ACEs is a journey, not a one-time intervention. So don't be afraid to say, oh, looks like you guys have been through a lot. Is there anything that you'd like to tell me about today? Or is there something that you're most concerned about today that we can help you with? And again, always remember to give advice only with permission. If any of you are familiar with the love and logic model, I like to use this a lot, where you don't tell someone what to do, even though sometimes we may know what the best next step is, but that you use well, I've heard other families that are going through this do X, Y, or Z. So you're not directly giving advice, you're actually giving them something to consider as an intervention or a next step. Next slide. Also be aware to take care of yourself. Asking about some of these experiences and the information you get back from families may trigger some of your own experiences. They may trigger some feelings of sadness and burnout. We always like to be mindful of that, particularly in the pediatric care setting. As we know, this is one of the most common places for compassion fatigue and worker fatigue and burnout to occur. what you all do is, I like to say, you know, it's close to missionary work. You're helping families and meeting them where they are in their lives, not only through illness, which you do a lot of, but you're on a journey with them to pursue wellness and have their children become the best and most successful people they can be. You're also the place where many families turn to for their deepest and most meaningful concerns. And so we want to make sure that you all take care of yourselves as well. Let's go to the next slide. So as far as your timeline, we are going to finish up training over the next couple of weeks. Blakeney will go have their training on August 26th and South Park on September 10th. And mid-September will be the launch date with your Canopy team support. After that, I'll be setting up monthly coaching calls with the sites. And I want to give you all just a few minutes for questions. Any pressing questions or things that I can address today? Any concerns?
So my name is Betty Fleming. I know I'm not supposed to do that, but I just did, sorry. Two questions. One I do not want you to answer, but I want to just put out to the group consideration, and one I'd like your opinion on. So the out to the group question is, we have a very real presence of ICE, that's the immigration services in the city that are, and deportation is very high, the fear factor, both in Texas and in San Francisco as well. Some of these patients may not feel comfortable even answering these or getting some of us involved. So that's a question for all of us that we may have to, at a later date, to talk about. The other question I'd like your response is, I'm a dietitian. So do you see any need for my services or where I can intervene for some of these toxic stress symptoms that come out?
Absolutely. So one of the very common clinical manifestations, particularly in the 5-year-old group, is onset of obesity. We have a good handout on nutrition, but the handout on nutrition is specific to nutrition and ACEs. So I could see that being a great tool for you to use. And again, we'll provide that to you in English and Spanish. Your clinical expertise for nutrition and health needs will be great, but the handout that we would likely ask that you would use if the symptom is obesity is to talk about how ACEs could be affecting and manifesting as a hunger drive issue or that type of thing. So we would just ask that you incorporate that into however you might deal with the patient. So in that intermediate risk category, we have handouts for the 6 resilience and protective factors, which are sleep, nutrition, exercise, mindfulness, and or mental health, and a supportive caregiver. So depending upon the symptoms that the patient may be experiencing, those particular handouts may be the intervention, and then to have some additional services like nutrition, dietary, or a social worker come back in and talk about maybe just healthy parenting. So the handout on parenting skills, or whomever might feel comfortable with regard to the mindfulness or stress reduction handout. That could be a nurse, that could be a provider, it could be a social worker. We can all develop a little expertise on mindfulness. Those are great points. I would like to point out on the bottom section of the questionnaire, those adversity items, deportation or separation is addressed there. So I understand your concern. I think there may be, given that knowledge, there may be a high percentage of patients who refuse to fill out the questionnaire. But that, again, just tell them that's okay. We just want you to know about this, and give them a handout on what are ACEs, and just keep asking. You know, I think families will come around as they see that and hear that other families have filled out the questionnaire and they weren't deported. So that's just going to be a question you're going to have to address. Again, why are you asking these questions? The critical answer is, we like to know what you've been through so we can understand how it might change your child's health or make them sick. The better we know you, the better we can help you. So just think about it in the context of knowing your patient. There is a universal need for people to be known by other people. And so I think making sure that we use that kind of verbiage instead of "we need to collect this information" sets off less red flags for families than "we want to know you, we want to understand what you've experienced, what you've been through." Our information is here if you have any questions. I know we've gone over just a few moments. Are there any further questions or anything else that I can, Murnell or I can address before we go today?
Can you just talk to why there are two sections on the questionnaire?
Absolutely. So the top section is are the 10 core ACEs that were originally studied and addressed in the Folletti and CDC study. So those are 10 core ACEs that have been validated through scientific study over and over. The bottom section are well-known, well-identified additional stressors that are somewhere in between social determinants and adversity that have been compiled through community advisory panels. And so those are actually open to be changed based on your community. They're pretty well documented social determinants, social needs that have been identified through the American Academy of Pediatrics. So again, the top are 10 core ACEs that all of the longitudinal study about health risks are correlated to. And the bottom are kind of long-standing issues that literature and the academy and community members have said are more social determinant adversity factors, and we believe that they should be considered in conjunction with each other.
Thank you.
Any other questions? You guys have been great. I find doing this training incredibly difficult via web chat and Zoom. You guys have been so interactive. I really appreciate it. It made getting up early today all worth it.
Thank you.
Thank you.
Thank you. Good luck. We'll be in touch. And please don't hesitate to reach out to us if you have questions. Have a great day, everyone.
You too.
All right.
Thanks, everyone.
Bye.
Bye.